center to our joint center seminar series. As Heather just discussed, there is a registration, one-time registration this year. It just takes a
Okay, well, looks like we just lost Norm. We've already gone through the registration. We can just go ahead and get started with Dr. Hendricks' talk, unless we just want to give Norm maybe like 1 more minute to log in. What do you think?
I'm happy.
There
he is.
He's kind of important.
Yes.
I'm sorry about that. I'm back. So when it says the meeting's being recorded, hit the continue and not the leave meeting button, in case anybody has that problem. Welcome back again to our seminar series, our joint center seminar series. And as Heather discussed, you'll sign up once and it'll be the same link every week following that. She will send out the announcements weekly so we know who is speaking. Certainly, if there are other individuals who you think might be interested in the seminar series, please absolutely feel free to forward the link to them so that they can sign up for the series as well. It's open to anyone who would like to attend in the United States or anywhere else. We still have a few slots left open for trainees. This year, we're expanding. Last year, it was largely focused on folks from the NIMH HIV centers, and this year we are expanding that to include as many different institutions across the United States as we possibly can. So if you have individuals, trainees especially, who would be interested in giving a 20-minute talk, we're going to have 2 trainees per day interspersed by full-length speakers. So please forward any suggestions to Heather and I, and we'll do our best to get everybody we can scheduled for this year. So this year, it's we're going to kick off the series with Dr. Craig Hendricks, who graciously agreed to give the first seminar, I think 2 weeks ago when I ran into him at the coffee shop, which he has been avoiding ever since. Dr. Hendricks is been at Hopkins now, I think for, is it 28 years? Is that about right?
Yes, I came here in 1984 and I left to be on active duty for 5 years. So other than that, yeah, but not all of it on faculty. I did all my training here.
Well, currently Dr. Hendricks is a professor, of course, and directs the Division of Clinical Pharmacology and directs the drug development unit within that division. He was educated initially with an undergraduate degree at MIT, and then started to work his way south, finishing his medical degree at Georgetown University, and then moving just a tiny bit further south over to Hopkins, where he has been for quite some time now. Dr. Hendricks has been intimately involved with antiretroviral therapies and the development and new delivery systems for antiretroviral therapies. As you all know, in the last number of years, there's been great strides made in implementing or beginning to implement long-acting regimens and other ways of delivering antiretroviral therapies that might be more efficacious for those who are infected and for those people who might be at risk for being infected. Dr. Hendricks is going to give us some background on that, as well as, I hope, talk a little bit about his own research that has a very interesting delivery method that hopefully at some point in time will be available over the counter for individuals. So Dr. Hendricks, please take it away.
Thanks for the introduction. I'm going to switch over to share my screen and just let me know if it's working. Is that visible for everyone? Great.
Yes.
Okay. So thanks very much for the introduction and the invitation. I'm going to focus this on pre-exposure prophylaxis, what we have today, what's expected in a number of months in the US and in sub-Saharan Africa. because there's a couple of things coming I think that are important, and I'll give you a clinical pharmacologist view of that. And then a couple of things, including some stuff that I've been working on, but only a little bit at the end, talking or near the end, talking about what's over the horizon, as well as some other approaches sort of in that same area. So these are my disclosures. The last bullet is actually a 2-paragraph. This is a summary of a 2-paragraph conflict of interest recommended language that I'm happy to provide upon request. So we're going to first talk about choices, the need for choices in HIV prevention, and I'm going to focus on biomedical prevention, not barriers of circumcision, which are both highly effective in preventing HIV transmission by the sexual route. We'll talk about some differences in at least 2 major long-acting formulations, but in addition, we'll talk about oral long-acting formulations in addition to topical and injectable, which are soon to be licensed, I expect. And then we'll talk a little bit about on-demand, which I think doesn't get very much airtime, but I think is very important. Then finally, we're going to talk about multi-purpose prevention technologies, which I think is going to be a new, very important area as we combine ways to prevent HIV and other sexually transmitted infections, or preventing HIV and preventing a pregnancy. And we will talk about contraception very much right at the beginning. So let's talk about choices. Speaking of contraception, if your interest was in preventing pregnancy, not preventing HIV, this is the array of options you would have today. If you're preventing HIV, this is the array of options you have today. And it always feels when you're in the middle of the field that there's, lots that's available. But the fact is, for cisgender men and transgender women, there is fixed dose combinations with Truvada or Descovy. This is tenofovir disoproxyl fumarate with M-tricytidine, and this is M-tricytidine with tenofovir alafenamide. I think the difference in these two are trivial, except in some established cases of renal toxicity. Maybe some other very rare reasons to use this, because it is much more expensive. There are now, I think, 3 or 4 generic forms of this available in the US. If you're a cisgender woman in the United States or anywhere globally, this is it. You don't even have this second option because Gilead decided not to study this in women. They are going to be studying this in the future, and I'll touch on this very lightly later. So these are the current options in 2021. I'm sure before 2022 is out, and probably before halfway through, we are going to have this many options that are licensed by the US FDA and quite a number of low and middle income country FDA equivalents. We'll have the addition of cabotegravir for cisgender men and transgender women. And in addition to cabotegravir injectable, we'll have this dapivirine vaginal ring, which is currently under review, I think, in 8 sub-Saharan African countries as part of the Article 58 agreements, as part of EMA and World Health Organization, and then those local FDAs. But I want to talk a little bit more about contraception, because I made a point that, even having those 3 in the next 6 or 9 months or so will, I think, be a huge advantage over the 1 pill once a day, or even less often for men that have sex with men and possibly transgender women. There's a systematic review here looking at 231 articles, and the conclusions there are that choice of contraceptive measures, not anti-HIV or PrEP, but contraception, is associated with increased contraceptive uptake, increased persistence, better health outcomes. And they also identify that choices as to what would be the primary choice for contraception, as with these needs, will vary over a lifetime. And the question we should be asking is, why should PrEP be any different? These are both sexually related, largely sexually related intersections in terms of behaviors that cause both of these conditions, if I may call it a condition. And if we actually look at more of this data, this is looking here on the y-axis at contraceptive prevalence, and this is the index of contraceptive availability. This is essentially the number of options for contraception that are available, like in that very early slide that I showed you from the Bedsider website. And from this data, each additional product option yields a 12% increase in contraceptive use on a population basis. And I think this is very strong data, these two studies together. And the question is, how much will this increase be for PrEP? I can't imagine it is going to be zero increase with additional options. And we'll see some evidence of that as we walk through some of the studies that I want to highlight. And then I'll come back to this again. You'll see this is very important with some of the products that are available. This is also in the contraceptive setting, that there's many factors that influence choice. It's not just a matter of what's the most effective that folks are interested in, but perceptions of safety are similarly important. In addition, control of the prevention, privacy, convenience. There's a whole manner of things, even just in this part of the slide, where there's very high percentages in terms of what's somewhat or very important to making these choices. And I think choice of an HIV preventive, when there are choices, is not going to be any less complicated. So it's important to think beyond just effectiveness itself, because many of these things will influence uptake and persistence and adherence with effective and even only modestly effective PrEP interventions. Okay, so let's start talking about PrEP itself. We're going to contrast 3 or 4 different types of long-acting PrEP. And I'm actually going to start with something that may not be on anybody's radar screen, but I think this is very important, because the biggest problem with the one pill once a day is that women, especially in sub-Saharan Africa, really struggle to take it for a number of reasons. This is not as true for these Dapivirine vaginal rings. Now, this is a silicone matrix ring. There's only 25 milligrams of the drug. It's a non-nucleoside reverse transcriptase inhibitor. This is not used for treatment. It is orally bioavailable, but not very well. So it was sort of a leftover, but has proven to be, as you see here, effective. And these are currently monthly rings, although there is now a 3-month ring that has been under study, and the pharmacokinetics and safety look good. And there is trivial systemic exposure of drugs. So that would result in far fewer systemic side effects, because there isn't any systemic drug. 2 major phase 3 placebo-controlled trials were part of the package that went to the European Medicines Agency and the package that is currently before the FDA. Aspire, which is a study done by the Microbicide Trial Network, and the RING study, which was done by the International Partnership for Microbicides, and the IPM actually has been the drug developer here in both. Now, at first blush, I got to tell you, this is kind of a yawner. When you look at this 27% and 31% relative risk reduction, this is in the modified intent to treat, and the modified is only excluding those that were infected before the study started, but that infection was not yet detected. These were very well tolerated, have excellent safety profiles. If you make an adjustment, and doing this with pharmacologic measures, and look at only the women that had high adherence in the study, that is, the ring stayed in place for most of the month, then you see that the protection goes up to 75 to 91%. Now, it's important because this is still below the high adherence levels with the oral FTDF. And as I said, FTAF has not been studied in the same population of women. We're going to come back to this in a little bit. There's 2 open label extension studies, HOPE and DREAM, and which were in just somewhat different populations. And these had very high uptake and even better adherence than in the randomized controlled trials, perhaps not surprisingly, because these rings had been proven to be effective. So I just want to interject this sort of prescient statement. This is way back in 1990, when the only microbicides that were under consideration were vaginal topical products, just simple gels, and not with active antiretroviral agents. Zita Stein then said, a less efficacious method for PrEP, frequently used, might serve the public health as well or better than a more efficacious but less frequently used method, and play an important role in preventing transmission at the population level. And I think this is really, the Dapivirine ring is the answer to this kind of a question. Now, I'm going to mention 2 studies here. This is HOPE, which I just mentioned briefly. It was an open label extension of the Dapivirine intravaginal ring. HPTN 082, the HERS study, was oral FTDF. And each of these captured data in a way that allowed us to break this down into persistence, that is, those that stay on the drug throughout the study. Adherence is what fraction of the participants took high or very high adherence. I think this generally means 6 to 7 doses a week for the oral tablet, and keeping the ring in for the vast majority of the full month, with only perhaps occasional ring removal. And then protection is the data from randomized controlled trials. I'm going to go ahead and give FTDF 100% protective efficacy because it is 100% when adherence is high. And I'm going to use the midpoint of that 75 to 91 as the estimate for the dapivirine vaginal ring. So if we take the product of these three, and this is a term that I'm kind of making up here, sort of this effectiveness min, what you end up with on the oral PrEP is 9% overall effectiveness. And because there's such a small fraction of the population that's both persistent and adherent, even though the protection is 100%. And for the ring, even though the protection is only 83% with high adherence, you end up, because of higher persistence, higher adherence, with a 41% effectiveness according to Craig, just in this subset. Now, you shouldn't let me get away with that. What you really want to know is if we did a randomized controlled trial and compared one to the other, what would that look like? Well, in fact, that study has been done. A lot of the data is still in analysis, but I can show you some of the data that I think is relevant in a number of these categories. In the REACH study, which is an MTN, a microbicide trial network study, the folks are randomized either to the ring or to oral PrEP, FTDF, for 6 months, and then they cross over to the other product. And then in the final 6 months, they get to choose whichever product they prefer. And we're going to just look at data here from each of these 2 6-month periods. And here what I've done is populated. Now, they didn't measure persistence in a way that I could compare across, but they did measure high levels of adherence. And it was higher, it was 22%, which is actually higher than this product based on this observational study. But this is most useful because it's in a randomized prospective trial in the same women. So this is the adherence during the oral period in the 6 months of the first 12 to which they were randomized to oral. The dapivirine high level of adherence is 50%. And then I'll use the same efficacy measures from the randomized controlled trials done previously. And I end up with, this sort of funny category that I've made up here, which is a product of these two, with 22% overall for the oral with these high adherers with a very high level of protection. And then even with a lower level of protection, still overall roughly a 2-fold improvement because of the higher persistence and adherence in this REACH study. I think this is a fairer comparison. These are a little bit closer to each other. And I think this is a useful lesson to take forward to understand the complexity of all the things that go into deciding for one product or another and how that actually plays out in the life of these women. Now, the status, as I mentioned a little bit before, it's been reviewed by the EMA under the Article 58 plan, and they gave it a positive benefit risk opinion. This was back in July of 2020. So under the Article 58, it then goes to the World Health Organization, which develops guidelines and does what's called a pre-qualification review. This was completed in January of this year, and they recommended the use of this as an additional measure for prevention in women at risk of HIV infection. And then it goes to low and middle income countries. This is not approved in Europe. The whole idea is that it gets a review that sends it forward with a recommendation that there is a positive benefit risk opinion based on the EMA review, and it is now under review in at least these countries in sub-Saharan Africa. It is also currently under review at FDA, although this submission was made later than the submissions in these low and middle income countries. Currently, there are ongoing or recently completed studies. I mentioned the 90-day vaginal ring. There is a combination ring with dapivirine and levonorgestrel for adding contraception into the ring, so that it's sort of a twofer with that product. There was the REACH study that I mentioned, which was the discrete choice experiment. I showed you some of the adherence data from that. And then 2 studies that are ongoing and near completion, both in pregnant women and in breastfeeding mothers. Now I'm going to switch to another long-acting. This is the intramuscular Kappaveer, an integrase transfer inhibitor. And this is the study schema. And this is very similar for both 083 and 084. 083 was in men that have sex with men and transgender women. 084 was in cisgender women. And they were both similarly sized. There's two groups, and basically they're randomized in the first step to take either CAB orally for a lead-in period. There was concern originally about toxicity that might occur, and you wanted to be able to stop the oral dosing, which would get the drug levels out of your body in a relatively brief period of time, rather than having the first exposure be an injection, which would be there for over a year. So there's this oral lead-in period in step one to either CAB or a lookalike placebo. And then injections begin, and there is an injection beginning at week 5 and then a month later, and then every other injection is at 2-month intervals for a total of 3 years, at least by the design. And then at the very end in step 3, they get rolled over to the previously proven efficacious FTDF orally. So they're on CAB or placebo Truvada, or they're on placebo injection or active Truvada. Well, both the 084 study and, the 083 study and the 084 study were stopped early because of superiority in both cases for the injectable Kappaveer. And here, a very high level summary is the Kappaveer arm in over 2,000 individuals, over 2,000 in the oral FTDF arm. And you can see in terms of the rates and the numbers, a difference statistically significant. The hazard ratio here was 0.32. So this is a pretty substantial difference here. Confidence intervals don't overlap 1. This is on the MSM and transgender woman side. And then looking at the similar kinds of numbers here, the hazard ratio is even greater in terms of an impact with the injectable compared to the oral with a somewhat narrower confidence interval. Now, this was not a head-to-head comparison of the men and the women, but I will look at these differences between this smaller hazard ratio of 0.11 compared to 0.32 and consider some of the things that might have gone into this. And I don't think it's clear what it is. And I think, in fact, it's probably a number of things. So let's look at that. So again, the hazard ratio is CAB-LA versus the oral FTDF. It's not compared to placebo, and that's not ever going to be done. The background HIV risk, historically, in randomized controlled trials, the incidence is higher in cisgender women than in MSM and transgender women studies. So this sort of does not favor, except that it might give more room for showing a difference in the cisgender women on the 084 side. As I mentioned before, the FTDF adherence is generally much lower in women. And that may have been a reason that there were some differences here. We don't have the data for the entire study to look at all of that, but I think the suggestions are similar. That the adherence was relatively higher on the FTDF arm in the 083 MSM and TGW study compared to the cisgender women in 084. There's also, I think, suggestions that there is a difference in the protective effect of FTDF alone. So that may also have favored more of a protective level on the MSM side. MSM adherence is less stringent. That is, you can get a higher level of protection with less adherence to the medication. And in some studies, of course, even an on-demand, only 4 doses a week as needed, rather than the daily dosing. So there's less adherence gets you more protective effect than the same level of adherence would get you protection in the women. The pharmacokinetics of the Kappaveer actually favor cisgender women. The trough concentrations, that is the lowest concentrations in this 2-month dosing interval, ends up to be higher generally in the women compared to men. And I'll look at some of that primary data in a little bit. And then finally, in terms of Kappaveer tissue pharmacokinetics, the cervicovaginal tissue levels, which I think are important in preventing sexual transmission in women, the tissue levels are only 1/6 of the plasma levels, but the levels in the colorectal tissue are only 1/10. So the levels are not as high. But there are other differences in these tissues that are also relevant in terms of transmission, which also, I think, favor protection in cervicovaginal tissue because it's harder to infect it in general. This is a list of stuff. This is part of the differential diagnosis. I don't think we're going to know what all of these things are true, but I don't know which of these things contributed to the differences that we saw in the outcomes of the two studies. I think the adherence in particular might be one of the biggest important differences. This is a summary that I think is very useful. I'm going to touch on this only briefly, and then I'm going to dive a little bit deeper into the pharmacokinetics of this thing. This was from the primary paper in the New England Journal led by Ray Philandidis, the PI for 083. And there are additional details I'll talk about from a paper that was published in parallel with that, led by Mark Marzinke and Sue Eshelman here at Hopkins from the Laboratory Center for HPTN on this study. And there's 4 categories here. Basically, this first group here, these are folks that were infected at the time they joined the study, but that infection had not been identified yet based on the testing method at the time, but it was confirmed they were infected, in fact, at the beginning. This second category are all infections that occurred in the tail phase. And this is after they went off the drug, so they're not getting any more injections, and they have this very long, year-long decline in concentrations. And there was concern that resistance would become an issue here. We're going to come back to this in a moment briefly. Turns out that didn't appear at all to be the case, in spite of some a priori concerns of this. The third category is lead-in period, oral lead-in period infections. And the challenges here, of course, are all the usual, taking one pill once a day kinds of issues that one might have. The important category, I think, is sort of the high adherence equivalent, which has been put forward as the thing that's really of the greatest value, assuming that adherence is not an issue in this setting. And I think, strictly speaking, it isn't as important, but one still needs to show up to the clinic, still needs to get a proper dose, and then see what happens. And I think in these 4 breakthrough infections, we'll look at these in a little more detail in just a moment. I think in 3 of 4 of these cases, there is a possible pharmacokinetic explanation. That is, the concentrations fell briefly to a level that was below the targets that were established a priori based on clinical treatment study data for cabotegravir and HIV treatment, non-human primate models, and in vitro models as well. So we're going to dig a little bit deeper into some of these. Now, I just mentioned that these concentration targets, you'll hear talk mostly about 4 times and also 8 times the PA-IC90, the protein-adjusted intracellular concentration that inhibits 90%. Now, this IC90 is used in a variety of ways, because in fact here, the 4 times PA-IC90 provides greater than 99% 2-log HIV RNA reduction as monotherapy in the treatment setting. So my only point here is that I think ViiV GSK was very rigorous and thoughtful in their selection of targets of 4X. And I'm also going to show you the 8X, because I think it may be important. It may not be a final decision for a target, but I do think it's important as a point of reference. So let's look at these. So these details were provided in one or both of the 2 papers that I mentioned, the New England Journal paper and a JID paper from the Lab Center, Mark and Sue Eshelman here at Hopkins. I'm not going to do these in order. I'm starting with sort of the clearest case first. This is the cabotegravir concentration on the y-axis. This is time on the x-axis. And I've added some things to this just for emphasis. And here's a case where this is when the infection was identified at the site based on the algorithm at the site for diagnosing infection was a rapid test and then an antigen antibody test. But all of these were retrospectively analyzed. And in this case, this is the sample that first turned positive at the laboratory center using a very sensitive RNA testing. And in addition, it was identified that this was a mutant, in this instance, a non-nucleoside mutation was identified. But by the time we get here to the diagnosis at the site, when the individual would then have been would stop injections, it did have integrase and integrase resistance. But let me back way up to here. I mentioned this 1X, 4X, and 8X times the protein-adjusted IC90 based on a number of external criteria. And if we look here, this is the concentration falls to right around 4 times PaIC90, which was a priori the established target. So it's just a smidge above that target only once under any observation during the study, at least as far as we know. But the time from this dip until the last test that was known to be negative here is 5 weeks. And we'll look at the same data for 3 other cases. And what you see then is if an exposure leading to infection might have occurred at a time when the concentration was lowest, although even right at 4 times the PaIC90, might this have been the point of infection somewhere in this window? And then the first diagnosis could only have occurred here, although we're only confident with this kind of assay sensitivity that it did not exist here 5 weeks after the trough of this dip, at least the trough as far as we know. And perhaps this persistence on drug was the reason to select for this integrase resistance that had not existed back here when the first, although retrospectively analyzed sample turned positive. So let's look at the others in the same way. So here's this dip that I'll refer to in a couple cases. Here's another one, also occurs very early on. There's a couple of concentrations here over a number of weeks where it's well below 4 times the PaIC90. The duration from this trough until the next test that's also negative is 8 weeks, a little bit longer than the previous case. Here was the central laboratory diagnosis of infection, and here is the site-specific diagnosis of infection. And in fact, there is determined to be an integrase resistance that's occurred here, perhaps again because of persistence of concentrations here before there was discontinuation of the injections. Third of 4 cases, here there's a couple of options. So here this is the very sensitive diagnosis. Here's the site diagnosis. This is not much of a dip. I'm just pointing it out. This is below 8 times the PaIC90. This is a longish time in my mind before diagnosis here. But again, if an infectious event has occurred here at a lowish concentration relative to all the other concentrations in this individual, and most individuals we've looked at so far, could this have suppressed diagnosis for this period of time that could only be based on the most sensitive assay, could only be detected this number of weeks later? I don't know. There's also a near 4 times PaIC90 exposure way back here, the same as in the 2 prior individuals I looked at, but this is a very long period of time, almost a year between this dip, if there were a potential exposure here, to think it might be suppressed sufficient for all of this, almost a year up until this time. So I don't know what's going on here. I'm just suggesting that I think some of the smoking guns may well be fall in concentration to 1 or 2 levels, either 4x or 8x. The only one that I really can't explain, here's one that this is sort of the biggest dip here. Here's another dip here. This is just above 8x. This is just below 8x, but a fairly long period of time. I'm not sure what to make out of this. To me, this is the only one that doesn't have a clearer explanation for what's going on in terms of perhaps a coincidence of exposure to HIV at the time of a nadir in concentration. And what's remarkable is that these naders in concentration are in fact different than most all the other doses received in these individuals. So a question is, what's going on there? Let me just comment on the oral arm of the study before I dive into a little bit more of the CAB data. In the oral arms, 2 of 39 infections. So again, and this is important too, not to be lost, only 39 infections occurred in the oral arm out of 2,300 participants. Only 2 of these infections were associated with either 4 or 7 doses per week adherence, which one would have expected to be protective. And in both cases, there was tenofovir NRTI resistance. In the others, in the 37 of the 39, there was clear evidence of preceding poor adherence based on pharmacologic assays. And in these cases, only 11% had evidence of resistance. So let me move on. Again, I want to highlight the importance here for CAB-LA and for FTDF. There were over 2,000 subjects in each, and there's a very small number of infections in each. I mean, both of these are highly effective. Overall, the incidence based on the rapid test and the antigen antibody test at the site was only 0.5%. But 11 of these 12 were diagnosed earlier by a more sensitive assay, and we talked about some of the importance for that. The incident infections were 1.7, so it was almost threefold higher. It was threefold higher just based on the point estimates than in the CAB arm, but still a very effective impact. Let me focus here. 7 of 16 resistance-associated mutations, but only 5 of these were integrase related mutations. 1 occurred among the 4 baseline infections. So these there was a dosing of drug, but before any of the injections. These occurred before the injections. There were 2 among the oral lead-in periods. There were none in the tail phase, which I think is very important because this had been a major concern early on. Again, it's not a large number to hang your hat on it, but it's certainly better than the other situations where there is perhaps persistent drug concentrations at a high level that could select for resistance, whereas here you have a falling concentration. And then importantly, there were 2 cases of integrase resistance among the 4 on-time injection participants, although as I mentioned, all 4 of these, at least 3 of the 4 had dips to below 8x or at or below 4x, as we just looked. So I think the key finding is the oral lead-in period is going to be optional in the open label extensions because the safety was so good. So they're just going to avoid that altogether. I think that's important because there was an infection risk because of poor adherence in that period. CAB-LA can delay the detection of infection. The question is the very sensitive and more expensive viral load testing necessary? Is it deployable? And I think most importantly, is it cost effective? It clearly would prevent more infection. The question is the juice worth the squeeze? And I think this requires a really hard look in going forward for rollout. Incident CAB infections occurred despite CAB with on-time dosing for the most part. And we took a look at those, and I think the smoking guns there, and this is because for me as a pharmacologist, pharmacology is the solution to answer to most of the questions. But I do think there is a chance that there was a coincidence of an HIV exposure with a relatively lower concentration. I mentioned the resistance that was seen there. And again, the summary that highly effective, both arms of the study, both the CAB-LA and the FTDF. So what is there to improve upon, and why talk about anything else for the last 20 minutes here? In terms of the failure analysis, again, an exceedingly low incidence. I think pharmacologic effects might explain a quarter of those failures. Virologic diagnosis might impact a quarter of those. And behavioral impacts probably influence 50% of those because there weren't behavioral problems based on those delayed diagnoses or the dips. The dips had nothing to do with the individual's own behavioral decisions. We'll touch on that in a moment. Now, I mentioned some differences in the pharmacology. This is looking at, this is an HPTN 077, a much smaller study that was done in HPTN. And what you're seeing here is that for the women in this study, the half-life was roughly 45 days. Excuse me, for the men, the half-life was 45 days, but in the women, the half-life was longer at 60 days. And in a multivariate analysis, these variables, sex at birth and body mass index independently, were both statistically significant as predictors for differences in the drug concentrations. And I list this, non-Hispanic Black was the only other variable in a multivariate analysis that was sort of less than 0.1, but I think this is also important as well. And these, again, were independent. So if we look in a little bit more detail at that, and that's part of the reason I said before that I think there are some advantages for women because their concentrations don't fall as much, and they're generally higher than the concentrations for men at the same point in time when they get their next injection, which provides an additional level of protection. Not to mention their cervicovaginal fluid concentrations are relatively higher. Now, some of that data was confirmed in this study that was done at 2 sites at Hopkins and University of Pittsburgh. And this, instead of, unlike 083 or 084, it was a single dose study, but we used ultrasound guidance by radiology to give the injection to be sure, we hoped, that it was intramuscular injection, not subcutaneous. And we measured cervicovaginal tissue concentrations and colorectal tissue concentrations, which is the basis of the data that I mentioned just a moment ago. If we look at the data here, this is the support for the data I mentioned, the cervicovaginal tissue data, with about 1/5 of the concentrations relative to what's going on in plasma in cervicovaginal tissue. And in rectal tissue, it's only about half of that, only about 10%. And this depends whether you're looking at peak concentration or the overall area under the curve, but clearly an advantage in cervical tissue with higher concentrations compared to rectal tissue, possibly contributing to the explanation for the differences seen in the men versus women in these studies. Now, for those of you that don't remember your anatomy, these are MRIs. This is the gluteus minimus. This is the gluteus medius, and this is the target. Here's the subcutaneous tissue. You stick a needle in here from a ventral position, trying to inject the drug in the substance of the muscle of the gluteus medius. And here's the gluteus maximus, which is what you're not trying actively to avoid, but if the needle goes in the right place, you'll hit the gluteus medius here. So I do this for orientation to this MRI part of the study that I just mentioned. We actually have looks, and even with ultrasound guidance, we had a retroperitoneal injection. This is all the way past the muscle, beyond the pelvic bones, not through, but through a little notch, just underneath the retroperitoneal, in the retroperitoneal space. There were intramuscular injections, which you see here in the gluteus medius. There were also subcutaneous injections, which you see here in the subcutaneous tissue. And then there were some mixed, and the mixed were dominated really by intramuscular injections. But I'm going to contrast the pharmacokinetics based on the location of the injection to suggest this may be an important variable explaining why women by sex at birth and why body mass index may both be independent variables, because both of those are populations with more subcutaneous fat that might make it more likely for an injection to be subcutaneous. So if we look at these together, this is, and again, this is only 6 subjects. I don't want to make too much of this, but what you see here is that the one clearly subcutaneous injection had a relatively slow rise over months to the peak concentration, and then a decline. So that if these injections, the second injection here is going to occur here while the concentrations are still rising, whereas for all the intramuscular injections, the concentrations are still falling. And most of these are well below the concentration at trough. So the troughs here with the intramuscular injections, at least in these 6, are all lower at the time of the next injection. This study only gave 1 injection. They're all lower than the 1 subcutaneous injection. I think it would be quite valuable to do more of this to be confident what's going on, because it may lead to a change in the way we recommend the dosing for this. So I hope that this isn't lost on the FDA when they're reviewing this study. Finally, in long acting, I'll just mention implantable antiretroviral eluding devices. There's a handful of things that are in development. Here's one example of these where there's a core that has the drug in the core. Biologic fluid comes into this implant once it's placed subcutaneously, and then drug that's dissolved in biologic fluids then moves out. These are being designed so that they could use commercially available trocars that are used currently for implanting long-acting implantable contraceptives. This is a comparison of the pharmacokinetics with an injectable every 2 months. This is Kappaveer data, and this is what may be an annual implant. And I've extended this falsely. You can see the fuzziness here. I falsely extended this. This is based on modeling that the belief is this Slatrovir implant will last a year. And you see the advantages that the implant flattens your peaks, raises your troughs to really optimize both safety and efficacy to avoid some of those dips that we saw, especially in men. It eliminates the long pharmacokinetic tail. It falls off much more rapidly. It requires, however, it also reversibly because it's reversible, it eliminates the need for the oral lead-in. It still requires a medical procedure, however, compared to a non-MD that could make this injection. And the duration can be, but the duration of this is thought that it could be as long as a year with this Slatrovir. It may be 6 months for a current TAF, tenofovir alafenamide implant that's already in clinical studies as well. So we'll have to see how that works out. I mentioned Slatrovir. I'm not going to say much about the mechanism of action, except that in addition to being a reverse transcriptase inhibitor, it's also a translocase inhibitor. It has very favorable pharmacokinetics, and its potency exceeds both emtricitabine by a lot and tenofovir by a bit at least. And the kinetics are also better than both of these drugs by probably a twofold measure at least. So it has some nice advantages that really makes it nice for putting it in an implant, because you can actually get enough in an implant that you can last a whole year. And this is looking at the actual data. This is the same thing I showed you a moment ago, but it's showing the actual x-axis. This is looking just at a 12-week implant and then withdrawing it and watching the concentration fall. It looks with models like this could probably last for a year. But it's also possible that the same drug in a monthly oral tablet would provide protection. So one pill once a month, not once a day, which I think could be a dramatic change without injections or implantations. It would require 12 months, 12 doses a year, but I think this could be a huge advantage. And this is just looking at the modeling. This is the observed data here in discrete mean and standards, and here's a 95% confidence interval. So the other drug that I'll mention, is the last new drug that I'm going to mention, is the Lena Kappaveer capsid inhibitor, which has some unique mechanisms of action. It's also very potent, picomolar potency. It also has a very long half-life. This is going to be a terrific combination with Slatrovir in the treatment setting in a fixed dose combination, and Merck and Gilead are working on that. This also looks very good in treatment trials, and there's two PrEP trials that are, one for sure is underway, and I think a second is underway in women, one in primarily assigned male at birth that are having sex with men assigned male at birth. And the second study, I'm not quite sure if this has actually started yet, but it's certainly been proposed and can be seen in ClinTrial. I think it's maybe not yet posted in clinicaltrials.gov. That's why I'm not sure it started. So I think this is also going to be very exciting. Next is on demand, and briefly the on demand thing is here. This is already proven effective. The Iprogase study was a randomized controlled trial where they compared daily FTDF to a 2-1-1 regimen, where anticipating sex, one would take 2 doses of Truvada and then 1 dose the next day and 1 dose the next day. So it's 4 total doses over 3 days. And here you see the Kaplan-Meier. Here's the placebo number of infections, and here's the active arm infections. Very high efficacy here, and it also is proving very popular in discrete choice studies, although, and these are of course open label, where infections are found to be very rare, if not non-existent entirely in these studies. And these all so far have been in the men that are sex with men and transgender women, although the numbers of transgender women are small. So oral on-demand works. Topical on-demand works. This is the original data from Comprisa 004. This was a tenofovir vaginal gel, and it was, sort of ho-hum about 35% relative risk reduction. But in those that had high adherence, it was 73% relative risk reduction. So it was in the same category as the topical vaginal. And I've always wondered if part of the reason for these imperfect but high protection in these topicals is because these are vaginal approaches and they provide no rectal protection. And on a population basis, roughly 40% of infections in these populations may be attributable to receptive anal sex on a population basis. But I don't know that for sure, but potentially very high levels of protection. The tenofovir elvitegravir topical insert, these are called inserts, not tablets, because the FDA, I think, wanted them called inserts so that people didn't swallow them. These are made for topical use, both vaginal and rectal. They've demonstrated protective efficacy in non-human primates. A first-in-human study with vaginal dosing met the concentration targets. And here what you see in blue is the elvitegravir above target, and then it falls off, providing protection very early, which is a problem for TAF. And then TAF comes up late, peaking around 24 hours, and then it starts to fall off here to below target. So providing protection with one or both drugs over a period of 3 days. We're going to come back to this. A rectal dosing study has been completed and is currently in data analysis. The last category I'm going to talk about is a subset of on-demand. These are on-demand strategies that are behaviorally congruent. Now, by that, I mean behaviorally congruent. It medicates a product that's already in common use. One could say that these are not necessarily behaviorally congruent, but this is an example where these are health fortifications: fluoride in the water and toothpaste, calcium and vitamin fortified bread, vitamin A and D fortified milk. But what I'm talking about here is medicating anal lubricants or vaginal lubricants, or medicating douches that are very commonly used prior to sex. And you can see the numbers here, but we're looking at anywhere from 60 to 85% of individuals usually or always use these lubricants or douches. So why don't we just add an active antiretroviral to the lube or the douche, because it's a behavior that already exists, and we don't have those issues with adherence that we had much earlier on, especially with the oral products. So this is a product we have been working on here at Hopkins. This is, and I'm going to talk primarily about this douche C. It's 660 milligrams of tenofovir, parent, not prodrug, but parent, in 125 mLs of half normal saline. The half normal saline compared to normal saline gets the drug much more rapidly into tissues. And here we're looking at active drug, tenofovir diphosphate, in rectal tissue homogenates. And I'm comparing this. This is our product C, our hypoosmolar. This is the first time we look. We have concentrations that are 1, 2, 3 logs higher than the target, which is the Ibergay regimen in the first cycle. So this is a true on-demand. And you see within the first hour, we've got a 2.5 log benefit compared to the current standard for on-demand. If you want to look at steady state, which is a 2-1-1 every week, then we lose 1/2 of those, but we still have a 2 log benefit. And the concentration here is observed to be higher than or equal to the current oral on-demand for all of a week, based on the data from our study. Now, in addition, I'm going to compare that to the data I just showed you for TAF. I can't compare it to elvitegravir because we didn't give elvitegravir. But if we compare it to the TAF concentrations, remember what we have here is a 2 log advantage here over the TAF insert, at least as formulated in this TAF elvitegravir fast dissolve insert. So I think we have some advantages that look good, but we only have one drug, and this may be an advantage for this rectal insert. Finally, this is just looking at pharmacodynamic data in our human studies. When we treat in vivo and then take a tissue biopsy and expose it to HIV ex vivo in an explant HIV challenge model, we see suppression of viral replication fully in most cases for a period of 24 hours. And then we see it comes back up around 3 days. And this is a very stringent assay. But if we actually test this in macaques, in a macaque rectal SHIV challenge model, if we compare it to steady state daily oral FTDF, so there's a lead in for a week to get the macaques to steady state, and then compare that to the product C I just told you about, and then we give a single douche 1 hour before the SHIV exposure, we have protection of 5 of 6 animals up here with the douche compared to 3 of 6 animals protected with the oral steady state FTDF, at least in the hands of our study team. So I think we have what looks like a reasonable product, and the plans are now underway to take this forward into extended safety phase 2 studies. And there's a lot of other rectal microbicide candidates under consideration. I just mentioned the tenofovir douche and the TAF insert here. Finally, multi-purpose prevention technologies to finish. The idea is that you would combine an active antiretroviral with a drug for pregnancy or a drug for other sexually transmitted infections in a way that would give you protection for a number of conditions in an at-risk population in a very efficient way to make adherence and dosing easier. And there is a wide array of different formulations that are mostly in very early phase studies. I did want to highlight an oral fixed dose combination, oral contraceptive and oral PrEP combined in a single pill. And this is in phase 3, phase 4. And this, in fact, really only requires a pharmacokinetic comparison because both of the active ingredients are proven effective in contraception and as PrEP, respectively. So I'll end with this, just summarizing. We talked about things that are available today in terms of short-acting and on-demand oral FTDF and FTAF, at least in the case of daily dosing, not on demand, has not been demonstrated. Tomorrow, very soon, in a number of months, we'll have a number of long-acting, cabotegravir and dapivirine ring. And then on the horizon, I mentioned some of these on-demand, including behaviorally congruent methods. And with that, I will stop and thank you all for your attention. Back to you, Howie.
Thank you, Craig. Very interesting stuff. We have some time for a few questions. Nobody has put anything in the chat yet, so if you have a question, please just feel free to unmute yourself and go ahead and ask.
Norm, I'd like to start things off if I can. Can you hear me?
Yes, we can.
Okay.
Yes, Howie. How did I know you were going to ask a question? Fire
I
away.
don't know. Maybe it's because of our combat experience of
Yes.
what we read. Yeah. Although I think you were a colonel, I was a lieutenant colonel, so I should.
No, I was just an LC.
You were just an LC. Well, I guess my memory recollection is limited. I'll have to go back to cognitive testing. Anyway, I just have a general comment and a question. I think the field of long-acting drugs is rapidly evolving. It's no trouble. Even in the last 6 to 8 months, work that's come out from Gilead and Merck, as you mentioned, and from labs like ours and development biotech companies that we're a part of are pushing a year long using prodrug assessments and steroid modified prodrugs for intramuscular injection. So I guess as the landscape improves based on what you said, these are my 3 comments, and maybe you can reflect this. Number 1 is adherence is probably the major issue. So if we can move to a year-long or a 6-month formulation, probably all those issues you've raised vis-a-vis transmission can be abrogated. So that's one comment or question. The second is the dosing volume, which you didn't mention, which I do think is important. We're giving them, at least in these contexts that you mentioned, we can watch these patients very cautiously and carefully. But you also gave some very, very significant data sets on how the injections are given. And obviously out in the field, we're not going to have MRIs or sonographies to monitor how these injections are administered. And that one patient on the sub-Q IM, the pharmacokinetics looked very different, very, very different. So injection volume, although not mentioned, I like you to mention it because I do think that's going to give us a much more accurate assessment of where we're going. And the third is if self-propagating, but I think it's not just us, but where the field is going as we get longer acting drugs and formulations, is the notion of how big an issue of toxicity might we see. Obviously, you mentioned that we won't have a lead-in or don't need a lead-in anymore because of the toxicities being very limited. But as we go further along, this may be more of an issue. So those are my 3 questions or comments that I thought you can extend. One is, again, has to do with dosing adverse events related to the adherence issues. And the third is the toxicity issues in the longer term.
Yeah, so I'll endorse everything you just said. I will address the 2, that these were 2 nested questions in there. I agree with all of your points, Howie. I think in terms of the volume is significant. I think that the part of the disadvantage is that volume, because it's limited, but it's limited because of potency primarily. So as potency increases, the expectation is if all things remain the same in the formulation that provides a long-acting release, that volume will decrease. And I think that will improve reduce the local toxicity, which is, it's interesting. I believe it, but I was surprised by the high level of acceptability of the weekly injection site the week-long injection site reactions every 2 months. So every time you can extend that interval, that's less of the injection site reaction. And I think in women, the data suggest that they should have the same level of protection at every 3-month injections, but that's not how it was decided to go forward. That's not under consideration for the agency, but based on modeling, I think that's a very clear, at least my recommendation for how it could be dosed. But I think getting that volume down will further increase the acceptability. The challenge with the injection, so I think these long-acting things, I'm sorry, your other question, be sure I get that, the toxicity, we're going to have to go through this oral lead-in cautiously for every new drug that comes along. I don't know how we can get around that, because for these drugs to last as long as we want them to last, and they're going to last even longer the next time because they'll be even longer acting for any of these, whether the sub-Q or IM. So we're going to have to go through these hurdles. I don't know how you can predict that you're not going to have some toxicity until you actively study it. But I do think there may well have been enough data before these large trials to have understood that, so that they might have avoided it. We had these discussions even in phase 2, whether or not we really needed it. But it's going to require some program to understand the toxicity, systemic toxicity, because of the systemic dosing, which again is avoided entirely by the topicals. Final thing is that, I'm excited by these long acting, but I got to tell you, when you ask people what they want, you've got some people that love oral, some people, maybe it's a big group, we don't know yet, that love injectables or implantables, and we got people that only want topicals. So I think we still have to be developing all of these areas, because the uptake is not universal in any one of these areas. When you actually ask folks what they want and then observe what they choose when they've had experience with these. So I think that's going to be an important area to understand what those are and provide the variety of choice so that we have something for everybody, and that choice sort of floats all boats so that the uptake and persistence is high for every person that wants protection.
Okay, thanks. Great answers.
Great, and we're a little short on time, but I did have one quick question I wanted to ask Craig. The idea of a tenofovir douche or any other single-acting regimen, I think is really timely, and it's a great idea to put something into a product that's already being used. There is some elimination half-life after that looked like it was about a week or so. Is there any risk of mutations or resistance developing over that period of time? Or is that too short of a period of time?
Well, so the question really is how long a period of time so maybe you're saying if there's an exposure, so there's a dose, there's an exposure, and then the issue which is not known is how long does the drug have to be there as the virus is also waning naturally. And it's the second part that is just not known. We know the kinetics well, it's the viral kinetics in site, and which site is relevant, just not known. And that would be another fun hour, but we won't do that. So I don't think that part is known, but what I will say is that based on the kinetics that I showed you, the current highly effective on-demand regimen is inferior in terms of tissue concentrations at all points of time over a week, even at steady state. So that if I come in with a single dose, I have higher concentrations locally, so that if local is important, and I will argue that it is, it may not be the only thing, but I've got 1 to 2 log superiority for 3 days, and I have some superiority of equivalence of local concentration for the rest of the week, even compared to steady state 2-1-1 dosing. So I think for myself at least, and I know that there are some others that believe, we're at the point of equipoise to take this forward, first to be sure that safety exists with long-term dosing, and then we'll find out. I don't know, my sense is that I don't know what the risk is in that long tail, but the on-demand regimen that's used orally has the same issue, and nobody's getting infected. So that dramatically reduces your transmission, your resistance risk. And I will say, in all the randomized controlled trials, tenofovir is the one drug that has the least resistance that's occurring. Both emtricitabine and cabotegravir, at least per infection, are having higher, for different reasons probably, having higher rates of resistance that is selected, presumably is selected for, compared to tenofovir. So I think there's a couple of reasons that I have some security in this approach, because it's not different than the current 211 oral FTDF approach.
Okay, yeah, that makes sense. Thank you, Craig. Scott, did you want to?
Hey, Scott.
Hey, Craig. Hey, so since this is a National Institute of Mental Health seminar series, I thought maybe we should say something about behavior, and you did. I signed on a little late, so I might have missed it, but I just was wondering how many of these trials, or I guess we shouldn't phrase it like that, but what about combining behavioral modification with these billion-dollar studies? I know there's not a lot of infections already, but do they all include some aspect of behavior modification to encourage adherence, to encourage condom use, and so on?
So two things I'll say to that. Well, I think in the last number of years, especially in the microbicide trial network, there's been a huge investment in capturing behavioral data to understand the correlates of adherence, uptake, persistence, and so on. In addition, I think to be fair, there's probably less emphasis on the barrier methods, although the barrier methods with best practices are all part of every one of the trials that have been done, including the phase 1 and the phase 2 trials. So I think there's a lot of data that's been gathered in terms of understanding the correlates. I think going forward, application of those lessons learned in phase 3 trials and other trials, but especially in phase 3, are being applied more and more, especially in demonstration projects, because I think a lot of the trials that we've talked about were done at a time, certainly the oral trials were done at a time where we didn't have lessons learned yet. We sort of learned in the context of those oral trials. We're learning this again with rings and again with injectables, and we'll learn it again with implantables, how to increase uptake and adherence for those products for individuals that would choose them. And I think a lot of this is coming out of these discrete choice experiments, which I did mention a little bit of this early on, where you randomize one or the other, you cross over, and then you give them a choice. And that provides a very rich set of data to understand what were the things that led to one choice or another, and also to look at the correlates of the behaviors that were related to adherence or not in those studies. So I think much more data is going into that. I think HPTN, which is inheriting much of the MTN, certainly the mandate to move some of these, especially topicals, forward, but HPTN will be looking at implementation, and much of their focus is to build this into the study design so that they take advantage of best practices based on things we've learned in all these prior generations of different formulations for PrEP.
Thanks. Great talk. Really enjoyed it. Thank you very much.
Thanks.
Yeah, and we will just close out by, again, thanking you, Dr. Hendricks, for a great talk. It was very interesting. Same time, same place next week. We are going to be running every Wednesday at noon Eastern Standard Time. Next week, we have Diane Langford, who will be talking about the self-serving side of astrocytes. So thank you again, Craig, and to all, be safe. We'll see you in a week.